perception or urgency. And it's very interesting. A lot of these patients don't present with fecal urgency or don't mention that they have this issue. And it's not until they actually come to see me that we realize this is an issue. There's patients with hyposensitivity where they simply don't get the sensation to go to the toilet, or takes them a very long time. And this is very much associated with passive fecal incontinence. And I find this very, very useful for patients and their parents, because I get a lot of them saying to me, my child doesn't have the urge to go to the toilet at all. And we find out sometimes that the sensation is completely normal and it's behavioral. So I find this test very useful tool for them to understand what's happening. This is all my 255 patients, and just gives you a mean of where my patients sit in terms of the 3 different sensations. Again, we need normative values for this, but it's something I will be publishing soon. And this just gives you a bit of an insight of our rectal sensation, again, patients. You can see the majority of them do have normal sensation, but there is a third of our patients who have impaired sensation. I'm not confident to say yet that, one particular type of sensation dictates which management plan, but generally those with hypersensitivity, I tend to play with their medication, their behavior, Botox seems to work well. All those patients with hyposensitivity, where something like irrigation or suppositories may be able to help them. What I found really interesting, which I'm sure we know very well, we found in our patients that who are less than 7 years old have higher urge sensation, and this finding may demonstrate is a demonstration of the withholding mechanism seen often in younger children when toilet training. As suggested by Rayo back in 2015, and what we see regularly in our own clinics, that most children either purposely or subconsciously, or who are unmotivated, withhold their stool, especially after passing a hard or painful or traumatic bowel motion. And their physiological behavior is altered, and thus they inhibit the urge to respond to defecation and avoid defecation altogether. And this would change their physiological and structural alteration completely. And of course, this leads to fecal incontinence or overflow, alongside impaired rectal sensation and the ability to have the normal urge to defecate. Rectal cessation has been a very useful physiological parameter to guide treatment, such as biofeedback, as we've heard about before in these patients, and one we need to further explore, I think. So I know there's been a lot of talks about ultrasounds, indoor ultrasound today, which I found really interesting. I'm just going to share with you my cohort. So we conduct endoanal ultrasound only when needed. So it's usually those who've had previous surgical intervention, particularly those with anorectal malformation, those who have a persistent fecal incontinence, especially if it's unexplained. And I think Benninger has demonstrated this in a paper where sexual abuse has caused anatomical defects in ultrasounds. It's something that we need to explore if you're concerned. Trauma in the UK, particularly London, trauma is something that we see quite often. And sphincter function, if that's very poor, then I want to look at the structure. So as you can see, we've only done 52, a small number, because I'm very, I don't want to expose them to something that they don't need to have. 53% had intact internal and external anal sphincters, but there's a small amount who have sphincter deficiency, thinning of the anal sphincters, or thickening of the anal sphincters as well. So I just want to show you literally a couple of cases which I find really interesting. Obviously, this is a patient with an with an anorectal malformation, as you can see on the right-hand side with their history. And you can see that there's not much sphincteric complex left there, and it'll be no surprise to me if the physiology is poor as well. So this is very useful to use both tests to guide management. But not all patients with anorectal malformation are going to do bad. This patient here has a beautiful intact sphincter, and hopefully the physiology would be normal as well. This is a patient with rectal prolapse, and you can see straight away, look how thick that internal anal sphincter is. And that just basically confirms that there is a structural component here that we need to look at. And this patient may need things like a barium proctogram or MRI proctogram. This patient, I remember I met here quite early on. They sustained multiple stab wounds in the abdomen and thigh and buttocks area. As you know, stabbings are quite common in London. And this, as you can see, there's not much of the sphincteric complex again left. And this patient has a stoma, and about a year ago I was asked whether they can reverse it. And I think that in this patient, they're going to be always leaking, so they'll benefit from a stoma for a long time, if not forever. So I find this very, very useful to use to complement the physiology. Another area is colonic transit studies. We use them religiously in patients that we see. We think it's easy, it's inexpensive, it's non-invasive. It's not very well standardized. Every hospital has a different way of doing it, which is a bit difficult to compare. The Royal London, we simply swallow one capsule 5 days prior to the x-ray. The one capsule has 20 shapes, and of course we can see the motility of the patient, and anything more than 50% is something that we need to explore. So you can see we usually divide them into normal or rectal evacuatory disorder, where all the problem is in the distal rectum, as you can see here on the markers, or in this case, slow transit, where the markers are scattered everywhere. And I use this a lot to show the patients what's going on with them as well, because if they're not compliant, or they think that there's something wrong with them, or the patients are convinced that the constipation is severe and it's not, an x-ray is something visual, something you can show them. And I find this very, very useful. So one thing that we've noticed is those patients with slow transit or rectal evacuatory disorder generally don't have very good resting mean compared to patients who have a normal transit study. One thing I would say is that just because you have a normal transit study does not mean that you're going to have normal physiology. So I think that's something, again, it's just bringing back the message that we have to use multiple tests to understand the full capacity of the problem. And we also found those who have abnormal transit studies also don't do very well on the bowel scores and generally how they view their condition. So going into a bit about the bowel scores, of course you can use any types, and they are time consuming, and I think they're very useful. We use the St. Mark's incontinence score, or what is known as the Vasey score, and anything above 5 is considered abnormal, and you can see that the mean for my cohort is 12. So fecal incontinence is happening a lot, and it's not very good. We did find a male predominance, and also we found that males tend to score higher on this score. We didn't find any correlation with this score with age or physiology or transit study. But what was interesting was that patients with fecal urgency correlated with a longer period of time of having their symptoms. So we found this very useful. This is a very simple pie chart. I just wanted to demonstrate here that, you know, not only do they have fecal incontinence, but this is occurring almost daily and weekly. So if you look at the green and the yellow, this is something that's happening on a daily and if not weekly basis. So it's an impact in their life. Most of them are wearing pads or nappies at an age they shouldn't be. Most of them don't even mention that they have fecal urgency. And like I said before, some saying that they're aware of the accident, some say they're not aware of the accident, which is where you need to question about behavior. So we use the Cleveland constipation score, which I've modified for pediatrics to assess the degree of constipation. I'm sure there might be better ones out there, but I find that a lot of patients don't want to fill out too many questionnaires, and this kind of answers the main questions I need to know. Anything above 8 is abnormal, and you can see the min of 15 here. So it's again not doing very well. Most patients feel incomplete evacuation all the time. What was interesting was that those who have abnormal transit studies reported higher scores on the CCS compared to those who have normal transit studies. Patients with abnormal scores again reported abdominal pain more so than those who had normal scores. But again, we found no correlation with this score with age, physiology, or how long they've had their symptoms for. I find this very interesting. This is a new finding, which is a paper I'm working on very slowly at the moment. I've divided my groups into all my groups altogether, 255 patients. Then I subdivide them into functional and organic. And as you can see here, the functional group seemed to do much worse on the scoring system, particularly when it comes to constipation. And I have more information about this, but I'll keep you in suspense when I work on more of my data. So moving on a bit about psychology, and of course I'm not a psychologist, but this is what I see and hear from patients every single time. I see a very happy patient, which makes my life very, very miserable. But this is what I see. They're very, very frustrated. They're very angry, and they want answers. And I think it's very important to look at impact of quality of life. I think we all know from the data that there's a lot of information out there about quality of life. It's devastating to the patient, it's embarrassing, affects their everyday life. And also what concerns me is the risk of distress. So we've had some patients who have been suicidal because of their symptoms, and it's something I think we need to assess quite early on as much as possible. So the 29% of my patients were borderline or very high risk of depression and anxiety. And this is based on the pediatric inventory emotional distress questionnaire. And what was even more distressing is that we found our scores, our mean scores, we compared it to the literature, and our patients with constipation score much higher on the distress score than oncology patients. And I think that's something that's it rings bells and is alarming. Also, what's normal is that you can have normal physiology and still be at high risk of distress, which obviously says that your symptoms is still there. We found that all normal physiology and risk of distress were found to be functional, mainly patients with constipation, all had abnormal bowel scores, all had abdominal pain. Half of them were double incontinent, all had very low quality of life scores. And what I found very interesting was the Cleveland score was a good predictor of how distressed they're going to be, which hasn't been found in the literature at all. As I said before, there's a negative impact, and it's also, as we use the PEDS quality of life questionnaire, both for the patient and the family. We found that males generally don't do really well in terms of quality of life. The bowel scores correlate with the quality of life scores, which indicate that the symptoms are affecting the quality of life. Those with abnormal x-rays generally have poor quality of life. And again, there's a correlation between the quality of life and psychiatric morbidity. So there is a very big component there, which is why I have a clinical psychologist on my team, because I obviously can't handle these patients on my own. This again goes back to my very simple diagram. It's very simple. I like it because it doesn't confuse patients and it works for all age groups. I ask the patients to score how badly they see their symptoms when I meet them, and 10 being the worst, 0 being the best. And as you can see here, the mean score is 8. So I very rarely see anyone who's happy and their physical and psychological state is very, very poor. And we did find a correlation with transit studies and severity, how they perceive their score, their symptoms. And we found those who had severe perception of their symptoms correlated with very poor quality of life as well. I can talk about management for a very long time, and it's something that I'm working on very slowly, but I feel like we still have a lot to learn when it comes to understanding the diagnosis and the symptoms. But this is kind of our philosophy that we use at the Royal London. So we believe we start off with very simple things like diet, of course, laxatives. Very often I get the gastroenterologists or pediatricians who don't use a combination of a stimulant and a softener, and I have to say, look, you have to do something like that to see that it's going to work. Toilet behavior is a big issue in all age groups. For some sort of reason, a lot of patients do end up sitting on the toilet for half an hour, 40 minutes. They use their little iPads or their phones, and they're not really concentrating on what they're doing. And they have no routine, so they might go to the toilet once a day or might not go to the toilet at all. And biofeedback is something obviously I'm not a biofeedback expert, but it's something I've been doing with my patients when I feel like it's needed when I'm doing anorectal manometry. There has been a lot of evidence out there that says it doesn't work long term, and there's been evidence that it has worked. I think the main issue, and I've speaking to Benica about this in the past, is that it's compliance. I think you can do a study and say that biofeedback doesn't work, but how do you know that they're doing it at home? Because how many of our patients don't take their medication or don't do their treatment? So I think we need to do a bit more research on this to see whether it does or doesn't work. But I find it very useful